Hello, everyone. I'm Tony Bernardo, Dean of UCLA Anderson, and I'd like to welcome you to today's discussion, Healthcare Transformation and the Role of Technology, hosted by the Centers at Anderson. Our centers at Anderson act as hubs for leadership insights, faculty research, student and alumni engagement, and service to our communities and society. They operate in such areas as finance, real estate, entrepreneurship, technology, media and entertainment, marketing analytics, and global issues that transcend borders. The leadership discussion today is part of a series of conversations created by our centers, collaborating in an effort to share expertise across all disciplines and to bring greater awareness of the problems and opportunities in the world around us and new paradigms for effective leadership. Today's discussion is also in collaboration with UCLA Health and the David Geffen School of Medicine, which have been terrific cross-campus partners for UCLA Anderson. We live in a world today with tremendous opportunities and challenges in every sector. We see the benefits of technology when dealing with challenging issues such as COVID-19. We see changes in the fundamental place of where we shop, are educated, and entertained in the current environment in light of the pandemic. We see notable best practices from abroad. We see a changing role of government and institutions, and across all areas, we see challenges to leadership that require an ability to conceive of new solutions, new business models, and new ways of engaging with employees and our communities. And these challenges fundamentally are more interdisciplinary and global, with a greater focus on the communities we serve and the society we are a part of. Today's program on the role of technology in healthcare transformation is a great example of the spirit of this collective effort, brought forward by our centers in collaboration with UCLA Health and the School of Medicine. I hope you engage in this program, learn from it, and ultimately lead in a way that benefits you, your organizations, our communities, and society at large. So please welcome Terry Kramer. He's the faculty director of the UCLA Anderson Easton Technology Management Center. Terry will be moderating today's discussion. Thank you.
Great, Tony, a big thank you. And let me just add my own welcome to all of you on what will be a hallmark discussion here in our leadership series as part of Centers at Anderson. And I want to just call out a special thank you to Tony, because Tony has personally been a big supporter of the Centers at Anderson and our focus on leadership. And as he mentioned, a big focus on the interdisciplinary nature of leadership and the importance of serving a variety of stakeholders, including our communities and our society. Now, in terms of the format here, I'd like to start out with some context on healthcare. I'd then like to get into the themes of our discussion. And then I'd like to do a formal introduction of our guest speaker. And let me just start out with a little bit of context on healthcare. First of all, according to a study by the Journal for the American Medical Association, the US spends about twice as much as that of 10 other high-income countries, all related to healthcare, in part due to the prices of labor, of goods, and of administrative costs. If you look at pharmaceuticals are about 4 times the cost of that in other countries. If you look at our healthcare providers, according to a recent study by the Kaufman Hall, they surveyed about 900 hospitals who showed a 19% reduction in their margins, in large part due to COVID and a decline of elective surgery. On top of all of this, contextually, we have big technology companies that are entering healthcare more and more. Amazon has recently launched an online pharmacy that has prescription savings that benefit their members approximately 80% on generics, 40% on brand name medications for those people purchasing without insurance. Amazon has also been doing a lot of work for providing healthcare for their own employees. Apple has been working with doctors to create a better ability to communicate with patients through Apple Health records. Last but not least, Google is doing a lot of work with an ambitious goal of using AI and data to assist with diagnostic capabilities to predict patient outcomes and to create better outcomes overall. All of this brings us to the interesting issue about what does effective leadership look like in this environment? How do leaders think about opportunities and challenges in this area? How do they think about what the role of technology is? How do they think about outside in disruptors and what role they will play, and who the successful innovators will be? Will it be entrepreneurial ventures? Will it be large established technology companies? Will it be partnerships between them? Other things that leaders have to think about is adoption of technology, of patients, of healthcare providers, et cetera. And then finally, on the most macro level, how do leaders think about the role of business in relation to government and societal needs? How do they think about the future of work with technology-based innovation that may fundamentally change the nature of the work for healthcare workers and in cases eliminate jobs? Now, I can't think of a better speaker for this event and this set of issues than Dr. David Feinberg, the head of Google Health. He had a 20-year career at UCLA. He started out as a child psychiatrist. He then took the role as the CEO of UCLA Hospital System. He's the Associate Vice Chancellor of UCLA Health Sciences and the President of UCLA Health System. Under his leadership, UCLA Health's patient satisfaction scores rose from the 38th percentile to the 96th percentile. Before going to Google Health and after UCLA, he was the president and CEO of Geisinger, where he oversaw 13 hospital campuses, which serve more than 3 million patients, research centers, and created better patient engagement. Now he heads Google Health, where he leads a team of Google's AI, product innovation, and hardware teams to take on big healthcare challenges. He received his bachelor's from UCLA Berkeley, his MBA from Pepperdine, and graduated with distinction from the University of Health Sciences Chicago Medical School. He's a well-known national speaker, is the author of numerous articles and co-author of Proven Care. He's a member of the Alpha Omega Alpha Medical Honor Society and a distinguished fellow of the American Psychiatric Association. Now, in terms of the format for today's session, I'll ask Dr. Feinberg a series of questions that are going to frame these issues and get his point of view, and then we'll use Slido for a moderated Q&A.
Well, thanks so much. I'm thrilled to be back at UCLA. I just wish it wasn't virtual.
Excellent. Well, a lot of us are feeling the same way. So let me start out, Dr. Feinberg. You've had a fascinating career. You started out as a child psychiatrist. You were the CEO of UCLA Health. You went to Geisinger, and now you're at Google Health. Tell us about your leadership journey. What were some of the major challenges and opportunities? And in essence, is Google Health the pinnacle of your career, looking at big healthcare issues from a technology standpoint?
Well, first of all, super excited to spend some time with you and look forward to our discussion. I don't think Google's the pinnacle of my career. I think the pinnacle of my career is when I was a fellow at UCLA in child psychiatry, and a dad came in from Las Vegas with his 12-year-old son. He was a single parent. Mom had left, and the 12-year-old son had a new onset psychotic break. And my job was to now give this information to the dad. And I had this tiny little office that you actually had to fold the folding chair so I could open the door so the dad could come in my office. Then I would close the door and put the chair down. And I thought I was super smart back then. UCLA child psychiatry was one of the best places in the country. I knew so much stuff. I was talking about neurotransmitters and dopamine reuptake and neuroleptic malignant syndrome. I was telling this dad everything about a new onset psychotic disorder. And this dad, who was a car salesman, a used car salesman from Vegas selling Cadillacs, he looked at me and he said, do I have to build a room out back? And I actually started crying. I know this was about 27 years ago because our daughter is 28 and she was a year old. And what I realized was the trajectory of their life had just changed dramatically. And it was really then, and I would call that the pinnacle of my career, that I realized what I wanted to do was make sure that I explained things in a way that people understood, that instead of being super smart, I became a partner and helped families and patients, and in this case with mental health issues, get the care they need, to make sure they got care that was accessible, that was dignified, that was culturally appropriate. Basically, I wanted to give them what I'd want for my own family. And I've actually just been working on that for the last 30 years. So Google is an amazing place because of our ability to scale and have impact. You know, UCLA, we care for about 1.5 million patients a year when I was there. First case of AIDS was diagnosed, discovered Herceptin, more organ transplants than any hospital in the US, you know, an amazing reputation on US News and World Report. Then I had the opportunity to go to Geisinger, where we cared for 3 million people, and we also paid for care as an insurer. But then I get to Google, and the scale and the impact has just been incredible to experience. You know, just with COVID, for example, our YouTube information page that our team did on YouTube for COVID has had 400 billion impressions. So we have the ability to do what I think I've been trying to do all along, is to make sure people get information in a way they can understand, and that at the right time and all that kind of stuff. So I don't know that the pinnacle of my career is now. I think the pinnacle of my career was when I was much, much closer to the front line.
Yeah. Excellent. And, you know, these themes that you're talking about how profound the product is here in terms of healthcare stands out, and the person-to-person interaction and how that matters. Let me segue then, you know, kind of talking about how profound healthcare is, et cetera, to the issue about the state of healthcare in the US. You know, some of the statistics that I shared where the costs are so high, and question about the outcomes. Does that worry you when you mentioned how important it is to provide accessibility? How do you think about the state of healthcare today?
I think in the US, it's a disaster. I mean, if I go back to my Los Angeles days, and you're driving from the beach on the 10 freeway to downtown LA, you could go right and end up in the south side of LA, or you could go left and end up in West LA, right? And life expectancy based on that turn could be 20 or 30 years difference. So it's amazing in the US that really what drives health outcomes is your zip code, probably more than anything else. And we've seen this now with COVID, where the rates of mortality for people of color is 2 to 3 times the rates of those that have better access to care, that have better ability to live healthy lives in their neighborhoods, that have less kind of chronic stress. So when we see it even with maternal death, I mean, it's terrible how much the US spends on healthcare when you look at our outcomes. It's inequitable. It's oftentimes inaccessible. It's oftentimes unaffordable. And our quality is not that great. So what we're good at is some of the real high-tech stuff, and I think we're really good at the innovative stuff. But if we're talking about taking care of people and taking care of communities, we have so much work to do to level the playing field.
Yeah. Dr. Feinberg, what caused this problem? Why are the costs so high? Why is the accessibility such a problem? We're in a great nation with a lot of resources and a lot of talent. How did it get this bad?
Well, we created a system that is really designed around providers instead of designed around patients. So when you design things around providers, especially in a fee-for-service system where you're paid for units of service, it's really the system created. The system output is doing exactly what it was designed to create, but you get paid more for taking care of complex patients with multiple medical problems. And the more interventions you do, the better you get paid, as opposed to being able to go upstream and keep people healthy and getting paid for outcomes and for better health. Actually, the reason that I was so interested after 25 years at UCLA at making a move and going to Geisinger was because at Geisinger, it's one of those few places like Kaiser and Intermountain and a couple others that has an integrated approach to care. So I thought if I went to Geisinger, I would learn the insurance business, because we have Geisinger Insurance as well as Geisinger hospitals and doctors. And I did. I learned the insurance business. But really what I learned, and I didn't get this until I got there, was what I learned at Geisinger is Geisinger loves, and I say that with a capital L, loves its community. And if you love your community, you start doing things that make sense for your community. Things like, well, if we provide insurance, not only is that great because we can keep the cost down. They didn't do it because they thought it was a good idea to have insurance. They thought it was because the community needed affordable healthcare. We created the largest biobank in the world of genetic whole exome sequencing along with phenotypic information, not because we wanted to create the largest biobank in the world, but because we knew that having that information in a stable community could allow us to prevent a lot of bad things from happening if we understood the genome. We started a program where we gave diabetics, type 2 diabetics that were food insecure, food for themselves and their families. Why? Because we really saw when we provided food to patients and their families that had difficulty getting healthy, nutritious food, it had amazing effects. It was great for their diabetes. It prevented diabetes in the rest of the family. It had a huge financial impact because we saw a decrease in healthcare costs. So actually what I learned is if you love your community, you create things that allow people to get great care. I would say some of the most state-of-the-art care that's affordable, that's accessible, and takes into account things beyond what you get at the clinic or what you get at the hospital. Because when you really look at health outcomes, only 20% of it has to do with your doctors and your nurses and your hospitals. The other stuff matters so much more. Your ability to get food, transportation, your genome, your zip code. So those things are not addressed uniformly and with enough oomph in the US healthcare system as they should be, or how we see it in other countries.
So then this leads into an interesting question about how do you fix all of this? And how big a role is technology? We generally think of technology as being something that can democratize service provision. We think about it in general lowering cost in many cases. We think of it being oriented around the use of data to understand better what you need to do. Do you view that technology is like at the top of the list to improve this along with the business model adjustments?
No. So to me, healthcare fundamentally is people caring for people, or people caring for communities, or communities caring for communities. It is truly a human interaction. The role that technology plays in that, it does not replace the care, but it certainly can improve the care. It can decrease the number of mistakes. It can improve the diagnostic accuracy. It can allow information to flow in a much more streamlined way so doctors and nurses are not spending time forced to enter information in computers, but rather can do what they're best at, sitting at the bedside or in the clinic, connecting with people. So I see it as an accelerant and an incredibly important and powerful and oftentimes underused tool to improve care. But to me, care is really a human endeavor of people caring for other people.
Yeah, what happens as time progresses with artificial intelligence? So, a lot of it's what we're seeing early on today. Technology can help automate more basic activities. But as time progresses and there's more access to data, the ability to understand that data, we're seeing artificial intelligence move more and more into the area of predictive capabilities, recommendation engines, autonomous vehicles, where that ability in some cases over time to pass up, to eclipse the ability of a human mind to assess things is happening or forecast to happen. Do you see that happening in healthcare over time?
Yeah, I'd say, Terry, it's already happened. So let me give you a couple examples from our teams. So one is, in the national health system in the UK, we created an app, and this app is mobile. And it basically tells what we would call in the US the rapid response team, the team in the hospital that gets called if a particular patient seems to be worsening that's already in the hospital. And the app just told that team if a patient's creatinine went up. Creatinine is a measure of kidney function. And so if someone's creatinine went up, you got a little beep, go see, the patient in room 6, their kidney may be failing. Okay, that was just creatinine. The app alone decreased the time to diagnose acute kidney injury from 4 hours to 14 minutes. There was a 30% decrease in those patients having a potential cardiac arrest and a 17% decrease in cost of care. So that's cool, all great. Mm-hmm. We then said, well, what if we did AI? What if instead of just looking at creatinine, we actually looked at 600,000 variables in real time? We did this with the VA on 70,000 patients. So say to the computer, find the pattern here about who's going to go into kidney failure. Well, instead of taking 4 hours to make the diagnosis or 14 minutes with our new app, we were now able to predict with 90% certainty, 48 hours in advance before any clinical symptoms, who would end up on dialysis. So the computer could tell you this patient who looks perfectly fine now, has normal creatinine, is going to be in kidney failure in 2 days. It's just like remarkable when you take that ability to be able to do what I think is now anticipatory medicine or make those predictions. Another example is what we've done with computer vision. So mammography. Actually, in the US, if a woman gets a mammography, it's read by one reader, one radiologist. In the UK, it's actually 2 people read your mammography. If those 2 people don't agree, it goes to a third person kind of as a tiebreaker. So we looked at both US and UK mammographies, and when our computer read the scans, we saw a significant, and I get these numbers backwards, but it was either a 5 or a 9% decrease in false positives or a 5 or 9% decrease in false negatives. So say one of those. But meaning that if a woman comes in and gets a mammography in the US, 5 to 9% of the time, we're saying everything's fine and there's actually a cancer. And another 5 to 9% of the time, we're saying there's a lump that needs to be taken out and it didn't need to be taken out. So pretty dramatic improvement in ability to read the mammography and not tell women, hey, everything's okay when it's not, and not add all the anxiety of you need a biopsy, we got a problem, and actually you didn't need it. Mm-hmm. But the important part in that study is that the computer did better than the human, but the computer didn't always get it right. There were also times where the human got it right and the computer got it wrong. So when you think about it, or back to the beginning of our discussion, these are tools that are best used when they're combined with the human. So for my mom or wife or daughter, what I'd want is a radiologist who's using AI together to kind of make decisions about what's going on. And so that to me is another great example of how AI can come into healthcare and make it better for everybody.
Yeah, if you were to fast forward with that same scenario 10, 15, 20 years from now, and I assume there's more data, more analysis, better diagnostic accuracy of the machine, what will it look like though? Will you find that having both the doctor and the machine working together isn't appropriate anymore because the machine is getting it right at such a level more than the physician that it negates some of that role of the physician?
So certainly I think we can get to specialty level or above specialty level. And we're in your question, can we get better than human performance? Mm-hmm. Absolutely. But I don't think that negates the human because, okay, now it comes back and with really good accuracy, we say, you got a lump and it needs to come out. You still need to have a conversation with somebody. You still need to decide, okay, now what do we do? Because it's very, very complex. We're talking about a human being and what do they want and what's going on in their life right now? And is this the right time? And how do you think about that with the other things that are going on with them medically? The only thing the computer did was get really good accuracy on the picture. But the picture for the human is so much more complex and three-dimensional. So I think in 20 years from now, I do not think that AI has replaced radiologists, but I'm positive that radiologists that aren't using AI have been replaced. So I really see it as a tool for radiologists to get even better and have more time to have the difficult conversations about, well, what do you want to do now that we have this information?
Yep. So let me ask you, as we keep advancing on this, I'm remembering your comment that 30% of these very, very high healthcare costs in the US are due to the healthcare provider, the physicians, et cetera, and 80% is all these other things. We're solving for a reduction in healthcare costs with good outcomes. So where does the cost reduction happen? How much of that is technology related, and what aspect of technology?
Well, so much of those are actually health outcomes that are related to your health, to your doctor and nurse. The other health outcomes that drive health outcomes are those social determinants, your genetics, your environment, your community. Technology can play a huge role there. When you think about those types of things, we've done a lot of work, our team, around genomics, and it's pretty advanced right now in health systems around some autosomal dominant types of disorders, or people heard of BRCA, et cetera. But if you get a little more complicated, there's probably multiple variants in there. And if you're able to predict that, that could be really helpful. Beyond the genomics is, what do we do to make sure people have healthy food, that they have environments that are safe, that literacy, as literacy improves, we know that health outcome improves. People say to me oftentimes, oh, tech is getting into healthcare and Google's getting into healthcare. Well, I think we've been in healthcare for a long time. If I go back over my career in the first 10 years, and actually that example I gave of the dad from Vegas, and I say this jokingly, I knew everything and he didn't know anything, although he ended up teaching me quite a bit. And then about 10 years later, or about 21 years ago, Google search hits the world. And now all of a sudden, there was this plethora of information. Now, granted, in the beginning, when folks came into me and they had done a Google search and they had printed stuff out, it was really distracting. But over the last 10 years or so, and I hope our team continues to push this, as we've gotten more authoritative information and really raised up voices of appropriate medical information, it's really fundamentally changed the relationship between a patient and a doctor, in that there's now, instead of this paternalistic relationship, there's a sharing of information. So getting authoritative information out there really allows people to make better decisions about their health, can actually do much more home care. When we built the new Ronald Reagan UCLA Medical Center, people thought we were building it too big because everything was going to move to outpatient. Well, a lot of things did move to outpatient, but more technological things came in and now the hospital's filled up. But look at all the things that are being done in outpatient are being done at home. That's stuff that used to be done in clinics or hospitals. So I think as we keep pushing care upstream, that technology can allow people to do more self-care, to be able to understand what's going on with their own health, take care of themselves and their families.
Yeah, give us some examples of that. So Google's in the process, I think, of closing out a deal to buy Fitbit. The idea of IoT, of Internet of Things and connected devices, is that an area that would notably facilitate remote care and better outcomes, or are there other things that you're referring to?
Yeah, I think we're actually allowed to talk about it. I think Fitbit officially closed today. So we're super excited to welcome the Fitbit team to Google. And I have my Fitbit on, and I'm one of those people that love to exercise. And if you actually took my Fitbit away from me today, I'd still work out today and tomorrow, right? So I'm one of those people. But I'm actually not typical. So really what we need to see is can these wearables engage the unengageable? And that is going to be, I think, a very complex undertaking. It seems to be that when you combine wearables with some coaching, you get pretty good health outcomes. Again, that goes back to my point that care is about people caring for people, and the wearable can be helpful. I don't know that it'll be a wearable on its own that solves our healthcare issues. Now, being able to identify medical conditions and monitoring people could be very helpful, but we have to be really cognizant of On the clinical side, it's got to be built into their workflow. But just coming in and showing your phone or showing your watch to your doctor or nurse is not particularly helpful in getting the right information to the right people. And so those are things we're trying to work on, is to try to make it easy and nudge you in the right direction if you're interested in improving your health. And then also using all of this sensor data in a way that's appropriate on the clinical side so they can get the right interventions. Your doctor really doesn't need to know that you did 11,000 steps today and 14,000 steps the day before and 6,000 steps. They need to know, are you active? So how do we do that in a way that allows workflow on both your regular life and when you're on the clinical side to be more, to be easier?
Yep. Good. And let me ask you one other one here, and kind of where are all these solutions? Telehealth. You know, in the COVID-19 environment, telehealth seems like it's ramped up. Are you a big believer that that is a future area that will improve access, lower costs, maybe even improve outcomes?
Yeah, so I think we were creeping up this curve on telehealth, and we were pushing really hard on it in the healthcare side. COVID happened. It's not even like we moved up the curve. We've gone to a whole different curve. And we saw a dramatic increase in telehealth. But I said to the team, I don't know that this is going to stay, because when you get back to, okay, now you're allowed to go to the doctor. If you think of a regular clinic, a doctor still has to have the office open, still needs all the support staff. Are they going to be able to go to see some patients in the room and then do a telehealth visit and go back and forth? It's going to be difficult. And we've already started to see some of the telehealth go down. However, for certain types of situations, it's incredibly convenient. And the more and more we focus around what's best for the patient, you're going to see more and more telehealth actually sticking, where we've seen this kind of peak and it's starting to drop now. We have to find ways that make it easier for folks to be able to access care. And yes, Terry, telehealth is one of those examples.
Excellent. Let me start interspersing some of the questions. We've got a huge number of questions here. One of the most popular questions is from Jim Jusko, who's on the faculty at UCLA, about Haven. Haven being the Amazon, JP Morgan, Berkshire Hathaway partnership to provide healthcare for their employees. And I know they was just announced they're going to break up Haven, but Amazon has said they're going to still proceed ahead on their own healthcare. Tell us about Amazon as a potential competitor, and what type of needle movement will we see on healthcare from them?
Yeah, so Terry, and I've said this to the team a bunch of times, our competition at Google Health is diabetes, cancer, inequity in care, depression, misinformation. That's who we're competing against. I think Apple has a great watch, and I hope they pick up a lot of people with AFib. I think Amazon is well positioned to think about providing care to people, and I hope they're successful. There's enough suffering out there for all of us to be successful. So I didn't come to Google to beat up on the other tech companies. I came to Google and want to be able to help as many people as possible. And I think a great example of that is our partnership with Apple. So we've launched an exposure notification both on Android and on the Apple phone that's been used in multiple countries now around the world. The US has been a little slow to uptake it, but California just launched it, California Notify. And this allows people, whether they have an Apple phone or an Android phone, to voluntarily, privacy-preserving way, be able to be notified if somebody they were in contact with under 6 feet for over 15 minutes is now COVID positive. So think about it. If I'm COVID positive, I can come home and tell my family, but if I was on a bus, I can't call the person I was sitting next to the bus 2 days ago because I don't know them. This app allows that to do it in a privacy preserving way. So there's plenty of suffering for all of us to win. I think the inequities in healthcare, the cost in healthcare, the actual disease burden is what Google Health is working really hard to fight.
Let me drill down on Amazon a little bit further without them being the good guys, bad guys, or anything else. Do they have what it takes to have a major impact on healthcare. And let me give you, as I think about Amazon, I think that they're great in three things. One is supply chain management from their core e-commerce business. Second thing is running a platform which matches buyers and sellers, in this case, healthcare providers and patients. And number three, the use of data, as we see with their recommendation engine. Do they have what it takes to be a major player in healthcare?
So let me tell you what I think it takes for one of these tech companies to be a major player in healthcare. And I'll focus more on how we're thinking about it, but it would be applicable, I think, to Amazon, and they're welcome to throw away or take my advice as they'd like. I think there's two things that absolutely are crucial for tech to be successful in healthcare. The first is I think it has to be done in partnership. I think we need to partner, tech needs to partner with the frontline people at the UCLA Health System today, at the Dave and Geffen School of Medicine, who have patients lined up in the ER. Because of COVID, they're treating patients in the hallway. They're nervous about going home and infecting their families. I think we have to be incredibly respectful of the professional caregivers. And we have to think that our job is to improve their ability to provide the care. So the first is partnership. Mm-hmm. So if Amazon was thinking about doing it alone, I would advise them otherwise. Mm-hmm. And then the second one is trust. And you got to this when you talked about data. Now, having been at Google for a couple of years, I'm convinced that our technology could save lives. The mammography story, the kidney failure story, I could give you 20 of those stories. This technology could save lives, I think, through partnership. But it will not work if people do not trust us. And so the trust issue to me is absolutely crucial. So if I were to advise Amazon, I would say they need to earn trust, and they do. When I order Amazon Prime, my stuff comes, so I trust them to send me shampoo. And I would also advise, and at least this is how we're thinking about it, that we need to think of ourselves as enablers of the true caregivers. And the true caregivers are the docs and nurses at the Santa Monica UCLA Medical Center today.
Uh-huh. One last question on Amazon. As you obviously know, with AWS, with their data center infrastructure as a service, they've had a playbook that basically says they're going to develop capabilities for their own internal need when they had to set up data centers for their e-commerce business, and then they open it up broadly to the public. Do you see the same thing happening in healthcare, that they're going to take care of their own employees first and their healthcare costs, wellness, et cetera, and then they're going to say, hey, we've got this thing working pretty well internally. Now we're going to open this up broadly. And to your point, maybe they partner to kind of keep the adversarial thing from happening. But do you see them opening this up publicly?
Again, Terry, I'll go back to Google. We follow a very similar playbook. We would call it dog fooding. So we would give there are things that people now know about, like Gmail and stuff like that, really start internally. And Googlers use it themselves. We're about just over 100,000 Googlers now around the world. And if it works for us, then we say, okay, now let's launch it kind of more outside. And we've done the same with our cloud services, right? So we have our Google Cloud platform that really started internally as a way for us to store, secure, and use data, is now, like Amazon and Microsoft, available as an actual business line. So I think that makes a lot of sense.
Excellent. Let me take some more questions here. Akhilesh put in a question here. How does Google view whether to spin out the healthcare company, Calico, Verily, or keep it within Google Health? How do you just think about the proper ownership and governance of the health initiative?
Yeah, so the Alphabet is our parent company. Our parent company has the big company within Alphabet is Google. Google Health is almost all of the health components within Google. And then there are two companies, part of Alphabet, that are health related, Calico, which is really looking at longevity, and Verily Life Sciences, which has done an amazing job looking at some hardware, partnering with pharma companies around drug studies and helping health systems move from fee from service to fee for value we all work together. And if you actually, my badge works at all the buildings, and we eat the same great Google food when we're back in the office at all the places. So it feels very Googly. And above my pay grade, there's some decisions around, taking outside investments at Verily and some of these other what we call bets that are outside of Google proper. Now, we all report up to the same CEO. So Sundar is my boss as well as the boss of the folks that are running Verily and Calico. The ability for us to organize and work together, we see as a huge opportunity. And I would even include beyond those, there's something like Fitbit, for example, is going to be part of our hardware team, but of course it's going to have important pieces. It's also going to have an important play with our Android. So these kind of what we call cross Google or cross Alphabet relationships at times are complicated, but I think also allows that innovation to happen in a real positive way.
Excellent. Another question has to do with data and data privacy. Healthcare is infamous for data silos, electronic health records, paper-based data, et cetera. How do we get a whole picture of patients with patients owning their own data? This is from Harish, who sent it in.
Yeah, great question. So let me answer it in two parts. One, it's on the clinical side, and then I'll get to the last part of the question for the patient. So on the clinical side, we've done a lot of work with Ascension and other health systems. Mayo's on deck, the National Health System in the UK, hospitals in India and Thailand. But with Ascension, what they've asked us to do in their different hospitals is to take an individual's multiple records. So when you get to a hospital, there's not only an Epic or a Cerner, there could be other things from an urgent care. There's multiple records. We have normalized that data and given it back to the Ascension doctors in a way that allows them to very, very easily find the information. Mm-hmm. Think about a Google search bar on top of a health record of a patient just for that doctor or nurse to be able to find things. So instead of the doctor saying, "Did you have a colonoscopy? I can't find it," they just start typing colonoscopy and it pops up. Or somebody sent in on a piece of paper that you had a pneumavax vaccine, misspelled, and we find that OCR of the pneumavax as the doctor types it and just pulls it up. So instead of organizing the web, we organize your records for your doctor. So that's one way that we think we can really improve that interoperability. And then you think about that, it's a pretty natural extension to be able to then think, well, what if we actually provided all of that information, because it is yours, to a patient in a way that allows them to understand their record?
And David, Dr. Feinberg, is it fair to say to your earlier point that not just finding the data, but eventually analyzing it and recommending and predicting is the natural roadmap of that offering?
The hardest thing to do is to actually get the data organized. Once we get the data organized, normalized, those predictions, Terry, blow my mind. I mean, it's just amazing when you let the machines do their thing, if you have normalized data. So getting the data, labeling the data. So even with the diabetic retinopathy, you show the bad retina to the eye doctors, they don't agree on the level of severity. And then you actually show them the same picture 2 weeks later. The doctor one doesn't even agree with him or herself from 2 weeks before. So we got to really say, what's the ground truth? But once we get that labeled data, and once we let the computer start to understand, and this can be all anonymized data, you can really then do those types of predictions and tell you what's coming next.
Yep. Is it fair to conclude from that the idea of self-care, the percent of what we do in our healthcare that's driven by ourselves versus a healthcare provider will increase? It may not be on the super complex areas, but on lifestyle recommendations, diet, other things, that self-care is going to become much, much bigger?
So we're building every product, and I exaggerate when I say this, with the following in mind, that hospitalizations are fundamentally, now I'm exaggerating because I've got in trouble for saying this before, hospitalizations are a failure of outpatient care. and a failure to predict what's going on. Outpatient care is fundamentally a failure of home care. And home care is fundamentally a failure of caring for your community. So if we really cared for community, if we look at chronic disease, 50% of it goes away overnight if people ate right, had access to food, wore their seatbelts, didn't shoot one another, had high literacy, et cetera. We could fix all that stuff. And that's taking care of community. So we are very much focused on moving care upstream. So we do think that self-care is really important. Over the last year or so, we've launched 5 screeners on Google that allow you to use clinically validated tools to do self-assessment. One is obviously on COVID. The other 4 are mental health. There's depression, PTSD, anxiety, and postpartum depression. So if anyone went to Google today and put in depression, you take a self-assessment. And then you can take a self-assessment. And with the self-assessment, we can then provide you with clinically validated ways to get treatment. And maybe that's a telehealth visit, like you talked about earlier, or maybe that's an app that does cognitive therapy for depression. But we want to take people from discovery of what's going on into action. And so we think we can close that. I am a child psychiatrist, so I saw this firsthand. But people with OCD spend 9 years suffering in silence on average before they tell anyone, spouse, a loved one, a clinician, that they have this thing where they keep washing their hands to where they keep bleeding, that they keep checking the door and they go back and back. Like you suffer for 9 years. What we see is they're coming to Google. And if we can get folks coming to Google to see, hey, you're not alone on this. Postpartum depression happens. Here's where you are. Based on those few questions we asked you. Again, we keep none of this information ourselves. It's all anonymous. You came out as moderate or you came out as severe. Can we then get you into treatment? Can we decrease that 9-year period? So we do think that self-care and self-treatment, even for complex things like postpartum depression, could be very, very important.
Good. And I assume, because it's one of our questions here, that there's been a lot of errors when people self-diagnose, that they're taking the wrong decisions, that's the area you got to be really careful about, that self-diagnosis piece. So the information you would provide, you got to be very thoughtful about that if people are going to take that and act on it on more serious items.
Super. And that's why the partnerships are so important for us. So many of the Google searches that you do, you not only see a bunch of blue links, you see what we call a knowledge panel. And the knowledge panel is curated information with a trusted source. So in the UK, it's with the NHS. In the US, it's often Mayo Clinic. So we're getting you to authoritative information because we're not making the diagnosis. We want you to do some clinically validated self-checking and then get you to the right people. Again, that's the partnership that's really important for us. And we see the same on YouTube.
Yep. Good. Sudhir asks a question here. Why is there so little focus on solving the more basic issues in healthcare, like lack of transparent and reasonably priced billing? So maybe this is a little bit of the Amazon question. If you could see what it costs to see a physician or the availability or outcomes, wouldn't that in and of itself create a kind of cost reduction effort that in and of itself is massive?
So it's a great question, and it's I'll try to, we thought a lot about it, that that information is actually available. It's just almost impossible to find. So what we're trying to do is surface that information during a typical health journey. And we've already launched some of this. So if you were to look up, find a doctor near me, we now have an ability for you to put in your insurance or Medicaid or Medicare to see who would be able to treat you in your neighborhood, right? So we're trying to show folks what the cost of care would be as they're in their journey. 70% of people within the 24 hours of making an ER visit go to Google, right? So we are, I like to say we are primary care, and we're open 24/7, right? People are coming to us with these questions. And that's exactly what we want to do, is to give them helpful information in their journey. The current administration in Washington, which I think only has a few days left, and the administration before, and I believe the administration coming, have all been pretty consistent on trying to improve transparency and cost in cost of healthcare. And Secretary Azar, I think, has done a great job on this. And we have said, if you get us this cost information, we will make sure that it comes up when people are doing their Google searches. So we've been very pleased with that, and we hope we're certain it's going to continue, or pretty certain, because we think it's really important. Now, does that decrease the cost of care? You got all this balanced billing and all this other stuff that can sometimes go run amok here in the U.S. healthcare system. But it's certainly a start to get that information out there.
So should it be like Amazon, that with that transparency, you can see products, pricing, ratings, that you're seeing more competition so that prices come down? Is that kind of the model on it, the vision?
Yeah. So, we think it's really important to get that pricing out there, and that does drive a better marketplace.
Yep. Good. Let me ask you a couple last questions. We only got a few minutes left. Tell us about adoption, especially in technology-based businesses. We often see a lot of great solutions, but at the end of the day, it's adoption that's the gating item. In this case, adoption by patients of technology-based tools or the healthcare providers themselves. How big an issue do you see that adoption is going to be, and how do you deal with that and overcome that as a gating item?
So maybe this will speak to how naive I am, but when I got to Google, I didn't know what UX researchers were. I'd never heard that term. When I was at UCLA, I would spend a couple hours every day at patient bedsides, like, how's the care? Is there anything we could do to make it better? The way we got patient satisfaction better was spending a lot of time listening to patients. I didn't know that was UX research. It just, to me, seemed like a natural. I get to Google and you meet these UX folks, and it just blows me away. I mean, when you think about Google, it's incredibly helpful in our lives. And the way that it's been helpful is incredibly sophisticated technology combined with a laser focus on users and what do they need and how do they solve the problem, and is it better if we put the click box over here or over here, and what problem. And when you think about Google or Gmail that starts answering some of my emails for me, in a sense, helping me complete it, when you first see it, you're like, wow. And now I think it answers some of my emails better than if I were to do them on my own, right? And so that's the UX piece. So those same people are sitting with the doctors and nurses at the Ascension Hospital and Mayo Clinic when we're doing radiotherapy and the NHS. Those same people, and I love it, so I stick my nose in, are talking with people who are using our products. When I first got to Google, I said, I want to be in the kitchen when a mom is doing a Google search about a sick child. And I want to be at the kitchen table, right? To me, that was like going into the clinic. I want to be where the action is. I think they looked at me always crazy. They set up a bunch of those. And I went into this woman's house, again, with permission. And she had 2 kids. Dad was going to be home from work. And you could tell the house was sort of upside down, but she tried to tidy it up because I was, this guest coming over. And she tells me that when she does a Google search of, like, my kid has a rash, she doesn't hit enter. She waits until the husband gets home. She goes on the other side of the computer. He hits enter because she's nervous what it could be, right? So that kind of understanding of users is so crucial when you develop products. The search, Google search, I think is fantastic. Like, it's amazing, but it's also the users. So that, to me, has been really amazing to see how Google has thought about it. And I think that's been a huge part of the secret sauce that's been successful for Google, is this really, we talk about the 3 values at Google are respect the user, respect the opportunity, respect one another. For Google Health, we changed that to care for the user, care for the opportunity, care for one another. But the user comes first.
Yeah. Where do the healthcare providers fit in terms of adoption? Are they going to be a bigger challenge using these tools you've described, or actually they won't be as big a challenge as the end user?
I think we're building the first technology, and it's built by doctors. I got a bunch of docs on my team, that was actually designed for doctors, right? When you look at the other electronic health records, and they're designed for coding and flow and record keeping and meaningful use and payment. But no one ever designed it for the doctor or the nurse, only with the doctor and nurse in mind.
Mm-hmm.
That's what we're building. And I think when you build those things, although you got to hold me honest, check in a month, I think folks are going to do backflips.
Excellent. Excellent. Let me ask you a couple last questions in the final minutes. If you were to put everything together, what you said, you talked about how a disaster healthcare is today in the US, all of these great opportunities. Fast forward 10 to 20 years, tell me what healthcare will look like and how does it solve the outcomes, cost, access related issues you cited at the beginning?
So I think a few things. I hope in 10 to 20 years that we've solved the inherent inequities and racism in healthcare. I hope that in 10 to 20 years, it's accessible and affordable. And then this one's, I get kind of personal. I hope in 10 to 20 years, those with mental health disorders are treated with the same respect and it's integrated into medical health care. And I think COVID, as bad as it's been, the silver lining is it's really demonstrated those three things. And I want us to keep the momentum to make sure in 20 or 30 years from now, everybody's getting great health care. Mm-hmm. The inherent inequities and biases are gone. And that includes those that are suffering from disorders that are harder to see.
Mm-hmm. Excellent. Dr. Feinberg, let me take a shot at summarizing the main takeaways that I got. This has been fascinating. By the way, I could talk to you for another 3 hours here. Let me take a shot at summarizing it. And I want to give you a chance to upgrade anything I said or share any parting messages with everybody here. So the first couple of messages is make sure we're all thinking about the context of healthcare well, that we're not in a good state right now, that you mentioned it's a disaster in terms of cost, access, et cetera, et cetera. That number two, a lot of the problems that are created are not with the doctors and the interaction with the doctors, but it's the downstream piece about zip code and our lifestyle and our choices we take and information we have access to, et cetera. That number three, that ultimately effective technology-based solutions are going to come from a partnering with healthcare providers as opposed to a frontal assault saying, we're going to replace, and that's going to be the most efficient way. Number four, that there are a variety of solutions that are available. 80-90% of what you talked about is heavily data and information oriented. What we do with access to data, the ability to analyze that data and provide that is heavily there, but certainly complemented with wearable devices and other things which create their own data. Number five is when you think about competition, don't get vexed on Amazon and others. The problem is so big that we need a lot of people going after these issues and more power to them. And the final message I got, number six, is some optimism. 10 to 20 years out, what you said that healthcare may look like is a pretty big improvement. This isn't incremental stuff we're talking about. This is pretty big improvements, and it is possible. Let me stop on that. Did I capture? Would you upgrade anything?
Well, you did a great job of summarizing. So I don't know that I can upgrade, but I will add to it. I think it's a moral imperative that we get this right. Not only will it literally save lives, if we continue to spend on healthcare the way that we're spending, and it becomes a larger and larger part of GDP with the mediocre to poor outcomes that we're getting, that also means that there isn't money to give workers increased wages. That means there isn't money to build schools, to put money into the arts. So I feel like we're stealing because we're taking a bigger piece of the pie and not delivering anything. So I feel from a citizen standpoint, it is our moral imperative to get this right. I think it's a national security issue to get this right. So to me, this is the priority. But I think you did a great job of summarizing. I think we're going to keep your talking points and add them to mine.
Excellent. Dr. Feinberg, let me just say a huge, huge thank you. There are very small, this is a leadership series. There's a very small group of people that are effective leaders. And I have to say, your style combines heart and head. It's a very interesting combo. It isn't just all this analytics and technology and this and that. It's from your very beginning start about dealing with the young patient, et cetera. There's a sense of heart. And I think your message about the moral imperative is key. And we live in times where we need big solutions and need to do it not because of ourselves, but because there's a broader imperative. So let me just say a huge thank you. I know everybody's learned a lot. I've learned a lot from this. I want to thank my colleagues at UCLA Centers for Anderson. I want to thank UCLA Health, who's partnered with us on this, David Geffen's school. And Dr. Feinberg, I hope we can have you back because we'll learn every single time we interact with you. Big thank you.
Yeah, thank you, Terry.
Great. Take care.